This is Damian McNamara with Elsevier Global Medical News, and I'm here at the Perspectives in Rheumatic Diseases meeting in Fort Lauderdale, Florida, and I'm with Dr. Sunanda Kane, who's a gastroenterologist and associate professor of medicine at Mayo Clinic in Rochester. Thank you for being here.
Well, thank you for having me.
My first question is, this is a meeting primarily geared towards rheumatologists and dermatologists, so as a GI doc, I just wanted to know what role you play and why you're addressing this audience.
Well, sure, and this is actually the perfect time to start being at these kinds of meetings. There's so much overlap amongst the different autoimmune diseases. It just happens that in rheumatoid arthritis, it's the bones that are destroyed. In psoriasis, it's the skin. But in inflammatory bowel disease, which is my area of specialty, that it's the GI tract that becomes damaged. And at the core essence of this is the same pathologic mechanism. So for us to be able to start talking and having conversations about, well, what have you done or what have you found that doesn't work? Those sorts of conversations are going to help us eventually help all of these patients with all of these different conditions. And certainly in inflammatory bowel disease, there are patients who have overlap syndrome. So they have rheumatologic manifestations of their disease. They have dermatologic manifestations. So I'm talking to my rheumatology colleagues and my dermatology colleagues anyway, and there is overlap with our therapies. So there should be overlap with our discussions and collaborations for finding pathologic mechanisms.
Now, in your presentation this afternoon, there's a slide where you say your drugs don't work, and that's the title of that, and I wanted to ask you a little bit more about what that means.
Sure. So that's really where the collaboration becomes important, because we know that there are so many drugs that do overlap. So adalimumab, infliximab, steroids, obviously, some of the immunomodulators. But then there are drugs that seem to work for rheumatoid arthritis, and there's many more rheumatoid arthritis medications available than there are IBD medications. And for whatever reason, whether it's trial design or whether it's just dosing issues, a lot of the rheumatology drugs don't seem to work in IBD.
So the differential diagnosis is really key to your specialty,
exactly.
Dealing with IBD.
Right.
And you're basing it on symptoms first and then further tests and that kind of thing.
Right, and our problem is that our gold standard is the biopsy that's obtained from a very invasive procedure, i.e. colonoscopy. And
so in the future you'd hope to move to something a little less invasive?
So we are moving in that direction, certainly with CT enterography, MR enterography, our video capsule studies, but those don't obtain tissue for us. And so, inflammation can be from many different things. It can be still infection, it can be neoplasm, so we could take pictures if we know the diagnosis already and use it. But again, then you're putting the patient at risk for radiation exposure every time you do those kinds of x-rays. A plain hand x-ray or back x-ray for a patient with rheumatoid arthritis, it's not that big of a deal. But when you're asking patients to drink contrast over and over again and shoot them with ionizing radiation, that can over time become a big deal.
Okay, Dr. Kane, thank you very much for being with us. This has been Damian McNamara for Elsevier Global Medical News at the Rheumatic Disease meeting in Fort Lauderdale. Thank you.
Thank you.